क्या करती है वैसे अगर आपको पेन टाइम में। मैम वीडियो वो शेयर हो रही है? नहीं 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 हो बढ़िया। ये इस पे चला कोई नहीं नहीं दिखाओ क्या बोलेंगे। याद करना। अच्छा इतना लेट स्पीच थी उसमें समझ में आया क्योंकि ये सेम चीजें बहुत रेफ्यूजी की पूरी लिखती थी।
It's not audible.
Good morning, sir. So do I start the presentation?
I think we can wait for Dhyani sir. Is there?
No, sir.
I think let him join. Then we can start. Can give him a ring.
Yes, sir.
If he's coming, then we can start.
Okay.
Dr. Aditi, is sir coming?
Good morning, sir. Sir asked to wait for 2 minutes, so just start.
अच्छा, ठीक है, ठीक है. So you can just start now as sir joins. ठीक है. I'll-
Good morning, everyone. Today I'll be presenting a seminar on migration and mental illness. The moderator of my seminar is Mr. Srinivasan. Migration is a pre-arranged global activity with the people as well as their part of their lives. Human beings are always moving from one place to another to accomplish their basic needs, to acquire changes in their life, and complete their dreams. The theory of leap, push, and pull. Push factors are that force a person to move, that is to immigrate, like job opportunities, education and economical growth, unemployment, underdevelopment, poor social economic status, lack of opportunity due to natural disasters and calamities. While pull factors are that encourage a person to a new place to immigrate, that is to get a better employment, more amount of wages, better working conditions, process of modernization and industrialization, technological development, cultural effects, poor quality of life, violence, and hostility between the nations. Immigrants or migrants is a person who moves to another place from his place of origin or wearing visas. A refugee is a person who has fled his country because he has suffered human rights abuse or because of other political and ideological reasons. An asylum seeker is someone who has left his or her country in search of international protection but is yet to be recognized as a refugee. The types of migration. Internal migration involves movement of person from one place to another within a state or country or a continent, while external migration is changing the residence from one place to another, usually in a different country, state, or continent. Population transfer. People migrate from one place to another in large groups when a government or a state policy or international authority forces them based on religion, also known as forced or involuntary migration. Impelled migration. Here the individual leaves the country because of unfavorable situations like warfare or a political problem, also known as reluctant or an imposed migration. Step migration is a series of migration which takes place in one person's life. These migrations are short, less extreme, take place from a person's place of origin to his final destination, like a movement from a farm to a village, then to a town, and finally to a city. Return migration is a process of voluntary return back of migrants to the place of origin. Seasonal migration is migrate to a new place for a period of time in response to employment or an unfavorable climate condition. The Ravenstein law of migration states that majority of migrants move a shorter distance. Migrants who move long distance tend to choose big city destinations. Urban residents are often less migratory than the inhabitants of rural areas. Families are likely to make international moves than young adults. Most migrants are adults. Large towns grow by migrants rather than the natural increase. Childhood disorder and migration. The formation of identity for migrants and refugee children is often a social mirror of new culture. Language and social acculturations may also accelerate gaps with parents, especially mothers who do not go out to work. Institutional cultures or institutional racism dynamics vary across high-income nations, shaping the child's experience of clinical, education, caretaking, and social spaces in areas like power, gender identification, representation of others, and religious identity. Looking at PTSD and childhood migration, in 2018, a Canadian report of PTSD variant of debilitating pseudo-seizures among Iraqi and Yazdi minority refugees have been linked to the traumatic separation of families. Pseudo-seizures were reported to be a severe variant of PTSD. Hundreds of child migrants traumatized by the anticipatory distress of deportation having reportedly given up on life falling unconscious or into a coma-like stupor, which is sustained on minor IV fluids despite having a history of normal active childhood. In studies on parental trauma transmission with Holocaust child parents, maternal PTSD rather than paternal showed increased child risk. Protective factors for children include intelligence and easygoing temperament, coping styles, the presence of at least one attachment figure, an indicator for emotional and social competency shows good global functioning. Suicide and childhood migration co-describe an intergeneration acculturation conflict model. The conflict relates to cultural problems, notably a feeling of incomprehension as well as a difficulty in acquiring a sense of belonging. Durkheim concluded that fast changes and modernization are a risk of suicide. Eating disorder and childhood migration. The eating disorder developed as a result of the migrant's trauma. The difference in the cultural frame between the country of the origin and the new country creates a psychic conflict within the child. It can be the underlying trigger to the emerge of the pathology. The eating disorder result from a process of acculturation. The aesthetic standards of the new country, which is represented by a thin body image, can induce disagreement regarding the aesthetic standards of the country of the origin of the migrant. Psychosocial mental health impacts of migration. In 2015, Sustained Development Goals, that is 8.8 and 10.7, recognize the contributory migrations and migrant workers marked to the global development. Despite that, WHO provides little or no reference to these migrant workers. Specific literature on stay behind has risen, primarily from studies on transnational families. Transnational families are families with members spread across national borders, yet who still retain a shared sense of unity or familyhood. The left behind families face adverse outcome, family dissolution, substance abuse disorder, child abuse, emotional isolation, and social stigmatization. In view of the previous literature, migrants, immigrants, and asylum seeker parents had higher risk of mental illness than childhood or any organic disorder. Parental migration also affects the psychosocial mental health of families, shaped by characteristics of the separation event, such as the duration of separation, the physical distance between the families. Forced migration. We see a massive population flow produced by wars, persecution, disasters, and other consequences of the global changes. In 2017, 16.2 million people were forcibly displaced. The number of forced migrants, those uprooted both within and outside of the country, has grown from 34 million forced migrants to 68.5 million, which includes 40 millions to be internally displaced persons, 25.4 million refugees, and 3.1 million as asylum seekers. An internally displaced person is a person or a group of persons who have been forced to flee and or leave their home as a result to avoid an armed conflict or a generalized violence. They have not crossed any international borders yet. While an irregular migrant is a person who crossed international borders without any valid travel documents. A stateless person is a person who is not considered as a nationality by any state under the law. Currently, the majority of refugees come from Syria, around 6.3 million, Afghanistan, around 2.6 million, and South Sudan, around 2.4 million. Forced migration set the stage for creation of a United Nations High Commissioners for Refugees, the international body responsible for protecting and assisting these refugees. People who are forcibly displaced are extremely vulnerable to being trafficked for prostitution, marriage, or slave labor. A large branch of research on the health of the forcibly displaced population has concentrated specifically on their mental health, which in some way has also contributed to the victim image of these refugees. What is micro-migration? Micro-migration may be defined as an exodus of modernization youth from the bondage of the oppressing traditional cultural values of their parents, extended family, or society. There are waves of population shift from poor rural areas to the rapidly developing and extending urban industrial metropolitans. This is known as internal immigration. Migration and mental health. The process of migration is a series of events influenced by a number of factors over a prolonged period of time. These phases in returns are influenced by other factors and at social and individual levels. At the level of pre-migration, social skills, concept of self, psychosocial, social and biological vulnerability play a role. This is influenced by the nature of migration, if it is a voluntary or an involuntary migration. Once the migration occurs, factors like negative and positive life effects, events, or bereavement issues become relevant. At this stage, a process of acculturation begins. That is, an individual acquires or adjusts to the new cultural environment of the new place he has migrated to. All the community and the personal factors, both in resilience and in vulnerability, will interact to produce a distressed state, which leads to schizophrenia and common mental disorders. Viraj et al. Did a study on migrant query workers in India, found neurotic and somatic symptoms along with poor awareness of mental health. Banan R et al. Did a study on Kashmiri migrants staying in the refugee camps. They found a higher psychiatric comorbidity, around 34%, including depression, general anxiety disorder, and PTSD, when compared to non-migrants. B.B. Sethi et al. In Lucknow found increased rates of psychiatric comorbidities, around 9.6%, compared to non-migrants, around 4.2%, seen mainly in the older age group. The general health needs of migrants and refugees. In 2015, the number of international migrants reached 244 million, which represent the 3% of the world population, with women representing 48%. The process of migration increased vulnerability of physical, mental, and social health issues. Health policies and strategies have failed to keep in pace with the speed and the diversity of migration and displacement. Early assessment of mental health in refugees, identifying and documenting injuries or trauma related to torture, finds this conversation itself in the middle of discussion of politics, in particularly migration policies, economy, human rights, and health policies. In Norway, the only required assessment is TB screening, undertaken at the so-called transition centers. These are the reception centers with very limited stay. In Norway, in 2007, a group of newly arrived asylum seekers were assessed using an individual interviewer that showed that half had anxiety symptoms or depressive symptoms. Richter et al. Looked into the frequency and nature of possibly changes in the psychiatric diagnosis of asylum seekers in Germany admission centers. It showed that PTSD cases increased while depression seemed to reduce over time. The Canadian Collaboration for Immigration and Refugee Health has developed an e-clinical checklist for new immigration and refugees. A screening instrument, the Refuge Health Screener, that is a 15 items scale, was empirically developed to identify common mental disorder in refugees such as PTSD, anxiety, and depression. Muse et al. Suggested by the Protect Project is a questionnaire to detect indicators of different kind of disorder, in particularly PTSD, was designed. The principle of post-traumatic management, the few key points are that the safety and protection from further threats or fear of future threats should be taken care of, comfort and consolidation for these migrants, immediate physical care if necessary, reliable supply and access to the basic needs should be provided, information should be given, reinforce the natural support system. Example, like no separation of family, appropriate places of work of worship should be provided. Facilitating a sense of being in control, promoting goal-oriented and purposeless behavior, help reunion with loved ones, and sharing the experience. The model of suicide risk in refugee and asylum seekers. Various psychological factors, personal factors, pre-migration difficulties, post-migration difficulties lead to suicidal risk. The key risk factors for suicide are in health system, there's barrier to access health systems by these migrants are unable to access the health system. In society, there's a culture barrier. There's a stigma associated with help-seeking behavior as well. In community, resultments, longer stay in detention centers, deportation, trauma, and violence also leads to a risk for suicide. In relationships, exclusion and lack of emotional support, a family separation is also a risk factor. Individuals suffering from mental disorders like depression, PTSD, and anxiety disorders, lack of religious beliefs, and financial distress also is a risk factor for suicide. This can be helped by assessing the health and the legal services, by having public policies, by having media effort to show these migrants in a positive way, by raising awareness, by early education on the language and culture of the host country, so that the migrants can get customized to the new country, to ensure communication between the migrants. The suicidal spectrum in a cultural context. Various pre-migration, migration events, and post-migration events. Like in pre-migration, the adaptive coping mechanism, the exposure to violence, the lack of service, and poverty. In migration events, the reason for migration, the nature of migration, if it was voluntary or involuntary, the trauma, the separation from the family. In post-migration, the strong ethnic identity, low religiosity, few reasons for living leads to acculturization, that is the change in cultural practices and values and identity. The recommendations to help these migrants to not commit suicide for service providers are to initiate a cultural change within the institute to make services culturally accessible and sensitive, to consider the likelihood of employing culturally broke or culturally mediators, which will benefit for both the clinical team and the local community, to make culturally sensitive services such as food and physical spaces available to these migrants, to make available information for immigrants by means of pamphlets in the preferred language, easily accessible, to make available qualified interpreters for patients not mastering the language of the host country. For clinicians, if needed, all mental health professionals should be trained in understanding the diagnosis, the illness behavior, and the culturally sensitive interventions. Information for minority groups in their preferred language about their rights and psychiatric disorders and treatment options should be available. To include cultural psychiatry as an integral part of an all curriculum for undergraduate levels. For policymakers must take a lead in ensuring that clear message on equality and diversity are enriched in law to cover all minority groups within the mandatory policies. And in these are the various studies done which show that Freda Nolly did a study in Sweden with a sample size of 149, in which suicidal behavior of 40% was seen. 40% people attempted suicide. In this model, 6 hierarchies and interconnected service levels of providing safety, nurturing care, giving environment, resilience through school and communication, trauma focus, or other psychosocial intervention, cost effective access to the mental care workers. This model takes into consideration that the portion of refugee child do not develop a mental health, some mental health issue, but they still require a surrounding that helps them grow. Coming to COVID-19 and the migrant workers working in India, internal migration accounts for the large population of 3.09 million as per the census of India in 2001, and by most recent estimates around 326 millions. The internal migrant workers are suffering from high degree of anxiety and fears due to various concerns in the COVID pandemic, are in need of a psychosocial support. Anxiety is forcing many of them to travel several thousands of kilometers on foot to reach their native place without any provision of food or shelter in the transit. Male migrant workers that are not residing with their family members, their loneliness itself makes them prey to mental illness like depression, loss of loved ones in the pandemic, and feeling of helplessness to attend the health needs of the family members. Staying away at village might also aggravate the stress level. These are the following references I have used for my presentation. Thank you.
I did a presentation, but one thing you should understand that the content is very good, but visibility is very important. A few of the slides are related or something. Okay. Otherwise, very good presentation. And migration, all of us know about it from the experience that when the person going to migrate to somewhere by crossing the borders or crossing the state borders. So every individual had a loss, something regarding the psychosocially, personally, and culturally. So other than thing, the pull factors, push factors also explained very well regarding this topic. Why they migrated, what are the reasons behind that. Other than that, we had experience in COVID-19. There are a number of migrant workers. They are crossing the borders, state borders in India, and currently there is a war going on Ukraine and Russia. These are also examples of like a psychiatric way we can be able to see like pyromanics versus PTSD. So the armed professionals creating a strife between the nations. They are creating the depression and other related illness in psychiatric way. There are n number of psychiatric team also working in Poland and other borders out of the Russian countries and Ukrainian countries. They help the people of Ukrainian. They provide support for mental health and as well as the social support also the people from Ukrainian. So topics it has the various views like man-made disasters, natural disasters. If anything happened in the nations, states, districts, whatever, but migration can be occurred. So the migration can occur. There are n number of results also. Outcome also people experienced. So, resilience also people we have to do resilience and other coping strategies and by personal life and family life and social life. So migration is a very good topic. So all of us understand better. I'm hand over to Professor Sir.
Migration mental status depends upon the interaction within the environment. Migration suddenly changes the social environment, the culture, and it causes some changes. It is difficult at times to differentiate of this emotional turmoil with the caregiving process. There are other issues also, like some cultural factors. So the cultural beliefs may not be understood by the clinician, that can cause a problem in diagnosis. It is well known that there are multiple studies that patients speaking foreign languages, they are more frequently diagnosed with psychotic illness than language that you can understand. So, apart from that, there are factors like in the slide show, the migration bulk is due to some catastrophes, war,
Yes.
for example, Afghanistan and Syria, now in Ukraine. But there are other migration mainly due to economical reasons. So, to club all the migrants as one may not be good. We have to differentiate why they migrated. So one population of migrants may have more problems. If they are forced, if they are coming from a war zone, if they are coming from distressful situation, then others who are migrating out of their choice are going into some other different things. So that is one thing. When it is difficult to adjust to these factors. So when we speak of migrants, we can't just we think outside the country. So people who have witnessed, for example, PTSD definitely will be more in people who are coming from war zones, not so much so from people who are migrating to US or some other countries because of professional reasons or financial reasons. So, it's a complex area. Still, as a clinician, you need to differentiate. You will face many times people from one country, how you assess them. It does create has its own issues.
Migration is a very controversial topic. Regarding as far as mental health goes, it is easier for people who migrate to countries with similar culture as theirs. Also, the people of host country are more open to people when they have the similar cultural background. Otherwise, acculturation becomes a very difficult process, and adults, children are easier; they acculturate easily. But adults, they find it difficult, and that creates a lot of political, social, and mental.
Do end the meet. End the
Dr. Aditi, just a comment.
yes.
I think very well presented. And I think this is a very burning topic because of Kashmir files also. And I remember a patient, who was a Kashmiri Pandit. He still comes for a follow-up, properly having delusional disorder. Something happens around him, some kind of an rule change or an administrative change, he goes into psychosis. And this started with their exodus when they migrated from there. That's what I want to contribute. Thank you. Thank you.
Thank you.